We would like to welcome our next speaker, Professor Mohamed Sameh Abdullatif from the United Kingdom. He will be presenting a lecture titled Lessons Learned from Manchester Terrorist Attack.
Right, good afternoon. Thanks very much for staying that late actually to attend this lecture. But anyway, I'll try to be as brief and concise as I can. Going over the next 20-25 minutes, I will talk about what happened in Manchester that day actually. I was on call, I was involved in the incident, and you will be very disappointed if you think that I'm talking about ATLS. It's not like that. It's actually all about organization and how it went that day actually. So what I'm going to talk about is the scale of the incidents, what exactly happened, the UK model of dealing with these incidents, the major accidents, like incidents like that, the lessons we learned from it. No system is perfect. Everything system had its defaults, and you learn from these experiences, and what sort of message we should take from it. So, talking about the scale of the incident, just to set the scene for you, basically, it happened on the Manchester Evening News Arena. It's a big arena. It takes about 21,000 people. Actually, that's the full capacity of it. It was a Ariana Grande concert. My daughter told me it's a very sort of famous heartthrob for the teenager, but this is the age group we are basically targeting here is anyway between 10 and 16 years old. These were the attendance on the day, so this is a sort of the part of the casualties at least, and it was fully packed, I'm afraid. Every single seat was taken on the day. This is just to give you an idea how the geography of the place. This is the Manchester Evening News Arena. Next to it is a Victoria Station. There is a car park, of course. And most people actually come by train. It's basically families coming from far away. Leeds is about an hour drive from Manchester. Liverpool is about half an hour, and Birmingham is about an hour again. So it's basically, you got people coming from everywhere to attend this concert. They should finish by 10 o'clock, and then they should take their kids home at the time. So this was the scene. Families were waiting for them. These are dads and moms and granddads and granddad moms waiting for kids, and then big bang, oh, it happened. Casualties ranges from casualties due to the bomb itself and casualties due to stampede, of course. So different sort of sources of that. There was a triage area, as you should have in this area, and it was at the entry of the station, the Victoria Station, as we said before, because it's the nearest. And the pump happened at basically the exit that leads to the Victoria Station. So it makes sense at the time to set the triage station at this particular area. So this was the scene. Injuries sustained from bolts, basically. So there's a bump and bolts. These bolts, yes, looks small here, but it actually was very big. It's equivalent to the diameter of the bolt is equivalent to 10p in UK, which is about £1 coin in Egypt, actually. So these are big bolts. They are not small bolts, very thick. And these are sort of injuries people actually sustained. This X-ray of the tibia and fib actually, it's only one bolt gone through this, so you can imagine what sort of size we're talking about here. We'll come back to the other X-ray in a minute because actually there is a story about this particular lady, but she's got a bolt embedded in the substernal area here. The bolt went all through from the back to the substernal without injuring anything, but we'll come back to her story in a minute. Just to compare this to another terrorist attack, which I was jinxed enough to be on call on the same day as a registrar in 1996. It was an IRA bomb in Manchester, big bomb. Difference between IRA bomb and what happens nowadays is IRA used to give you a warning of 20 minutes to half an hour before the bomb goes off. So you know quite well where it will go off. And you get injuries mostly from stampede, people running away from the incident rather than from the bomb itself. You get very few casualties. We were 5 miles away from that incident, and we only get people walking through the A&E. But this one was a bit more nasty. The casualties, we're talking about 59 casualties and 19 fatalities on that day, so something actually equivalent to what happens to the London bombing in 2007. The first call came to the ambulance crew about 10:30. First response 10 minutes later, and the major incident declared around Manchester about 14 minutes later. Model of dealing with this in the UK. How do we deal with it? To start with, what's an incident? An incident is any occurrence that presents threats to health, community, disruption of the services, and cause or likely to cause such a number and type of casualties that a single trust might not be enough to deal with it. It could be a major incident, like individual trust can deal with it, or ambulance crew from a single trust can deal with it, and that's like a multi-vehicle car accident. It could be more extensive than that, like our bomb, for example, where a single hospital cannot deal with it. It could be something catastrophic. We're talking like swine flu in infectious terms. It could be like a volcano or an earthquake. How it may present. It may present in different ways. A big bang, like the pump. It could present like a rising tide, like infectious diseases, for example. A cloud on the horizons, like the Chernobyl or the volcano in Iceland a few years back. Headline news, like personal threat, maniac going shooting everybody, like what happens in the States. Something internal, like hospital-acquired pneumonia or diarrhea, or deliberate release of chemical materials. So this is how incidents like this actually present itself. Just to imagine how the hierarchy of actually the setup in the UK, you got the Strategic Health Authority, like the equivalence of the Ministry of Health here, something at the regional level in Manchester, followed by the primary care trusts. These are people actually like GPs that holds money, and then they give obviously that money to individual accused trusts to spend on patients. So this is how it works. In 2005, the Department of Health basically came up with, we have some system before to deal with these incidents, but they came up with a white paper of how to prepare actually for such incidents. The main, basic things in this paper is to ensure that the NHS is capable of dealing with it, but also ensure that we've got a speedy recovery, because don't forget that we have emergency patients, we have patients waiting for cancer surgery, and they have to be dealt with. So we have to have a speedy recovery. There is certain factor that should underpin the practice in individual trusts. So every single trust in the UK have a system in hand that's underpinned by this system, like information sharing, communication with public, and most importantly, my problem is exercising and evaluating plans. You have to exercise all the time. Exactly what you're doing with ALS or ATLS, you have to exercise these. Alerting mechanism usually comes from ambulance service or police fire service, and they distribute the information to the individual trusts. But it could also come from strategic health authorities, because like with infectious diseases like Ebola virus and swine flu and these sort of things. The hierarchy, which goes at the level of strategic health authority, but also at the level of the hospital, comes from strategic group, the gold group, they said. They have overall command of the situation and overall responsibility, followed by the tactical group, the silver group, and followed by the operational group, which is us actually dealing with the patients at the shop floor, if you like. Allocation of casualties usually happens, depends on the location, where did it happen, number of casualties, services needed for these patients, and triage level, what sort of priorities actually they have. And triage, as we all know, goes into 4 stages, something like having a patient who can walk out of to the casualty, or dead people, immediate threat to life, or delayed. So they have injuries that's not life-threatening as such. So in Greater Manchester, we divided at that day into 3 categories. Priority 1 patient went to hospitals very much near the incident, about a mile from it, and they take the biggest hit. These are the priority 1 at the top. And then my hospital is Stockport Hospital in the middle there. We are 5 miles away from the incidents, and so on and so forth. People who can walk basically gone straight away to casualty further away. So on the scene management, what happens on the scene? As I said before, there is a triage area. The triage over there, I come back to this point, this is very important actually, the triage is very quick. Okay, so things can be missed. Or what happens if the patient can walk, they walk. If they are not breathing, they are dead. And then depending on the respiratory rate, they decide actually if they are immediate priority 1 patients or urgent, so priority 2 patients. So basically, the triage aim is to identify the patients with our urgent life-threatening condition and to determine where can you cater for them. Every patient should have a priority card stuck to his body and they've been flown by the ambulance to where they should be dealt with. Once that happens, the ambulance crew phone the individual hospitals. When the reception actually receive the call, they have to have certain information from the alerting mechanism. This can take the acronym of something called CHALE or methane. In our hospital, we use methane because there's more information in it, like what is a type of the major incidents, how many casualties, if there is any contamination or not, and the number of casualties, of course. So the reception take this information. The first person he communicate this information to are the gold and the silver command people, followed by people like us, myself, I was on call. So they give me a ring and say, stand by, there is major incident around Manchester. I know, of course, because it was on the TV on that day. And then what happens is a standby. Standby means that preparatory arrangements should be made. The first thing that should happen, for example, is A&E should be evacuated from all patients. It takes a bit of time to do that. You'll be surprised how much time actually it takes to do that. And then when they activate the mechanism, all the resources should be activated, so all the on-call people should be directed to A&E if they can help, and then to be distributed where they should be dealt with, either to intensive care or through the theater. And then at the end, when all casualties cleared from the scene and none en route, they basically scale down the incident. So that's the usual routine. There's a control room in every trust. Deal with those. It has to have a TV screen so they can see information from outside. They have to have a phone and they have to have some sort of communication rather than the landline between themselves. This is basically a very schematic diagram showing how the hierarchy works in my hospital. So you have the chief executive at the top, and then basically the head of each department in the silver hierarchy, and then everybody else actually on the bronze. Every one of them know exactly what they do. They have a card, and on this card is displayed their responsibilities on the day, so there is no confusion whether they are gold or silver. Once the patient arrives to A&E, they take him through to A&E. A&E, bronze people like myself, the consultant anesthetist on the day, I'm the consultant intensivist, the A&E consultant should be there. We all have tabards. The purpose of these tabards is to identify different persons because we might not know each other. So we have to identify what's the responsibility of different people. The good thing about the tabards as well, in the pocket of each one of them, there is an action card. So the action card tells you exactly what's your responsibilities on the day. The biggest action card, of course, is the A&E consultant action card, who is responsible for evacuating and mobilize resources, followed by other action cards. So you've got action cards for the triage nurse, action cards for the anesthetist, for myself. We all know what is it, but it's better to have a reminder. So I know, for example, that I should go to ICU, should prioritize patients who can go out, escalate the number of beds. So I went down from 16 to 20 level 3 beds. The charge nurse, give order to charge nurse to start calling people just to get some more resources on. So everybody knows. Even the receptionist actually have an action card. Even people in the mortuary have an action card, because at the end of the day, you don't know how many diseases you will end up with after you have the first wind of these patients. The triage cards come in different forms, but we use that one because it gives you some much information on the day, so you know exactly quite well how it works. The aim of the triage in this area is to provide ongoing assessment of the patient, to reduce the congestion as much as you can. And you will be surprised how much congestion you get. There's people coming from different directions to try to help, but actually you should have adequate number of people, not too much, not too little, because it's counterproductive either ways. And to provide information to the patient and families, and that's very important. So patient come through the door, they actually allocated to the priority area they should go to, and then go to ICU or theater or the CT scan, depends. On the A&E, there should be a board displaying every single patient and with the sort of comments to display the type of injuries they sustained. But also the reception takes some sort of information from the patient so they can contact the GP and get more information about the history of that particular patient. So this is how it works with us. Once the incident finished, we have to have a debrief. The debrief is, there's 3 types of debriefs. A hot debrief that happens immediately after the incident finished, and that's basically to see what happened, how many casualties I've got, how are we going to deal with it. And the cold debrief happens usually 2 or 3 days in the same trust afterwards, and the reason for that debrief to see if the recovery phase is completed and the level of service in the hospital goes back to normal. And then the Strategic Health Authority debrief is about having a feedback about the whole incident and how we dealt with it, and if we dealt with it according to the recommendations. That takes us very nicely to the lessons learned from this incident. And I cannot iterate more that the fact that there is no system that's perfect. There's lessons learned from every one of them. And I choose to go through these lessons learned from the scene of the incident, from the receiving units, and from the SHA basically debrief that happens 2 weeks down the line. Let's start with the scene. The most important message from the ambulance crew on the scene is the first ambulance on the scene should be discarded. What happens usually, the ambulance come in, there's loads of casualties, as we said, 59 and 19 fatalities. This ambulance actually totally emptied from resources. They take syringes from it, they take monitors, they take oxygen, and so on and so forth. So this ambulance shouldn't take any casualties back to the acute hospitals. So whenever you have one of these incidents, you should send 2 ambulances, not 1. One where it should be emptied and go without the patient, and the other one start to transfer patients to the acute trusts. One looks trivial, actually, remark, but it's very important that every single ambulance left the siren open. When you imagine the chaos on the day, it's very difficult to communicate with the sirens going on. People shouting, relatives shouting, and people screaming. It's very important to shut the sirens down once you arrive on the scene, but that has been missed. Going back to the lady that we talked about before, when we talked about the perfect triage, there is no perfect triage in these incidents. Okay, this particular lady was a grandma of a particular kid on the scene. She had 4 or 5 bullets going through her back. 1 fractured the femur, 1 fractured, 2 in the abdomen, 1 beside the spine, but just missed the spine. And this one gone all the way from the back to the front, set in the substernum without injuring anything on the CT scan. The only thing about this lady, I did a TEE or theater because I'm aware that with these swerving bolts, it has a tornado or a hurricane type effect. It can cause intimal injury without causing any problem. So you end up with probably a dissection, and she had that, which is a bit surprised. My consultant colleague was a bit annoyed of me insisting of having a TEE despite having a CT scan. But she ended up, after sorting her femur and her abdomen, she ended up transferred to the cardiothoracic unit because we don't have cardiothoracic in our hospital. Another thing's missed is a tourniquet. Tourniquets have been left. In the chaos of stuff, people arrive to the hospital and they still have the tourniquet. What the military people usually do is put a T on the leg. So when you do a secondary survey, you'll find the T, you know the patient had a tourniquet. But in the panic of dealing with these patients, things like this can be missed. Receiving unit lessons. System can get saturated very quickly. That's what we imagine. I remember quite well, it's 4 of us, 2 consultants, 2 registrars, and we suddenly got 4 patients. Everybody deal with 1, 2 of them has to go to the CT scan. So I think after this incident, we decided that despite having enough people, we should call for 2 from every specialty, 2 consultants, 4 registrars, and so on and so forth. That goes back to my important remark, actually. In our hospital, what we have usually is the A&E consultant and the intensivist deal with the overall running of the floor in A&E. Surgeons have no say in it because, with all due respect to our surgical colleagues, they are task focused. They think longitudinally. We look at the big picture more often than normal. And I was discussion with another colleague of mine who works in Central Manchester Hospital. Their surgeon starts to be involved very early, and it was chaos, while us actually haven't. So it's very important to follow the rules where an intensivist or an A&E consultant run the shop floor on the first incident. The other thing that we found out, that the surgeons themselves found that they are task focused. So they have to have a commander surgeon that basically run the floor for the surgeon. Okay? Sorry, I may take 1 minute or 2 more. No, I'm very sorry about that. On the floor for the surgeon, they task focused, they focused on what they should do, but he basically communicate information between them, told them what happens outside the OR. It have no clinical intervention with meaning at all. Going to task focus, it's very important in this instance where you have 15, 20 casualties to be task focused. For example, there's no point to do an RF. You have to do external fixation for this because that can take 20 minutes. The ORF will take half an hour, 45 minutes. There's no point of doing that. You have a big queue of casualties waiting. You have to finish off with it. The other thing that we found that military assistants was very useful. They have certain tools, like certain drills, that can basically make you deal with this X-Fix in 15 minutes rather than 20 minutes, which saves a lot of time, actually. The 90% rule. Again, the 90% rule says not all the shrapnels have to be removed on the first visit to the operating OR. Again, you have a queue of patients waiting, so you remove 90% of them. Some of them tricky, you leave it. Patient can come on the second day because there's another patient waiting. The second visit, you remove 99%. The third visit, 99.9%. We all forgot that these bolts are evidence, actually. And I'll come back to this in a few seconds, actually. They are important. They are evidence because they have some sort of information that we need to know. People started to throw it away and we retrieve it back. The reason they are evidence are, some of them are cause toxicity, like the copper bolts, for example, and some of them are contaminated. The memo we got from the Strategic Health Authority next morning said some terrorists, and I'm afraid it's sad but true, they contaminate them with HIV blood to make sure that they've got the maximum casualty as possible. If they can't get hold of HIV blood, they contaminate them with feces. They have nasty infection. So this is evidence and you have to keep it. So every single patient actually 2 or 3 days later has an HIV test for this particular reason. What we learned as well is have a dedicated blood transfusion practitioner on the scene in A&E was very helpful on the day. Cascading information is very important. It happens in our hospital where the panic is the whole thing. They forgot to tell us that they stand down. So we carried on waiting for patients for ages. Information hasn't been cascaded, but we got there at the end. We knew what happened, really. Organization lesson is the last thing that I will talk about. Very important to plan beyond the day one. The reason for that is there is in Greater Manchester after this incident, there's 400 hours of operating after day one in these casualties. So we have to have plans beyond day one. Because of the nature of the casualties, there was an issue with the critical care facilities. But what had been decided is all the children go to adult ICU. And you may find this because of the nature of casualties you get. Communication is very important, and the gold and the silver team found it useful to use WhatsApp between hospitals to communicate very quickly. My last thing, because our hospital has a big problem with the media in the past, don't volunteer to speak to the media. You have to be media trained. You don't have to be famous in this situation. You have to be safe, really. They're nasty, they can imagine things, and they can twist some sort of information to basically suit what they wanted to say. And don't underestimate the emotional impact, not only for patients and relatives, which you choose, considering the age group we're talking about, from ourselves as well, actually. I cannot deny that I have a bit sort of affected me. You wake from this 2 or 3 days later, and you feel a little bit down because of the context where this has happened. These are moms and dads and grandmoms and granddads waiting for their grandkids or kids coming out of the hospital, and they got injured because an idiot basically decide to blow himself off. When you put it in this context, you feel a little bit down, actually. Take-home messages, this is the world we live in. We have to be prepared. It's better to be prepared than sorry, all have to have a major incident plan. It doesn't matter if you're in Egypt or in England, you have to have a plan to deal with it. You have to have a plan that suits your geographical resources and resources as well. But you have to have one, and you have to practice it, okay? We have an Operation Socrates 1 month before this happened, and it makes a huge impact, actually. That's just a rehearsal situation for more major incidents like this, and it worked. You don't have to be there. I didn't go, but they recirculated the information, and I read through it. Last but not least, you can attend courses. The MEMS course, the Major Incident Major Management and Support course, is a very good course for that. The UK International Emergency Task Register is another course, but it all goes around how we mobilize resources, how we deal with these humanitarian situations. It gives you the basics to organize this. This is Brigadier Tom Hodges, who came to speak to us afterwards. He's the inventor of the MEMS course. It's very useful, I have to say. And support for people is the main issue. It's the main, actually, thing, the main positive thing in these situations, really. You got loads of support. I can tell you tens of stories about how taxi drivers taking people home for free, have hotels actually have opened the doors for relatives for free that night. Support is very obvious. Support from your colleague as well, because you need to support each other on that days. Otherwise, you will end out those post-traumatic stress disorder. There's no doubt about it, really. And thanks very much for being patient.